Hello, this is your brain on drugs, and this is the punk rock psychiatrist. Today, I wanted to go back. I had a couple of episodes on talking about the effectiveness of antidepressants, and then one on improving the effectiveness. And I wanted to kind of just throw in like a part three on the effectiveness. There was one point that I've had on my mind for a long time, and I didn't bring up in the episode. And then it kind of led me to think of some other things, and then basically I'm concerned maybe I made it sound too much like these medications aren't that effective, and I wanted to kind of put some balance to that, some counterpoints um, that you could keep in mind about that they may be a little bit more effective than some of the stats suggest. So I've got several points. A couple of them I just wanted to or kind of review from last time. So first, just talking about that placebo response, I talked about that a lot, where like 80% of the response is placebo, but versus the drug, but you're not going to get that placebo response if you don't take the drug. So taking it becomes important, right? And that's why I like to base things off of side effects, because if we can minimize side effects, then we can maximize the ability of the patient's going to take the medication, and they're going to probably get just a very similar placebo to all the different treatments. So why not give something that has less of that? But there's a couple more points I'm going to talk about with the placebo response. So when we look at the data, I went over the effect sizes of all the different medications and talked about how they were pretty low. So there's a lot of difference between how these meds are researched and how they're used in practice. And we talked about the placebo response can vary from the prescriber to prescriber. Some prescribers may give very little placebo effect, some may give a robust effect. Well, typically in these scientific trials, the patients are getting a pretty robust effect, right? Because they're often getting checked in with weekly or more often. They're being offered, they're getting more attention, they're getting more consistency, and just kind of the thought that they're a part of this trial may make them feel a little bit more special, which can infer some more placebo effects. So some of the positive effect from the med may be watered down by this more robust placebo effect. So that's one thing to kind of keep in mind. But that the how they do these trials is not how it's practiced in the real world, right? I'm sure they try to mimic that, but there's so much variability in patients, so much, and you also have to think about how do they select the patients. A lot of patients are excluded that are patients we see in the real world, right? That maybe they have some confounding factors and things like that. Maybe certain groups are represented less well. So it's not really in reality what we deal with, and it may not properly measure what we're actually going to see out in the real world. So it's and that goes for any med, but I think it's in any kind of categories of meds outside of mental health. But I think it is especially important for ours because of the way kind of that doctor patient relationship can be a little bit more important. All right, when you're dealing with sensitive topics like this. um, and another point is that it's not clear, you know, when you try to divide it out and say this is the placebo response and this is the antidepressant response, there may be some overlap there. Okay, so that is to say, some of that placebo response may be actually some drug response too, and some of that drug response may be placebo response. So there may be some overlap in those responses. Just maybe like a synergistic thing, like taking the antidepressant and the placebo together confers some sort of middle ground, and if you took the placebo out, you'd still maybe have a stronger antidepressant effect than you're measuring. Okay, if you just kind of subtract out all the placebo, some of that placebo, there may be some antidepressant effect built into that, and so that may kind of water down the effectiveness. All right, so that's one point, right, with the placebo and the way the research is done. Okay, another one, I talked about this a little bit. The diagnosis can be very important. We talked about how those with more severe symptoms tend to respond better, and so those with mild to moderate respond less well. So that can be a big factor, in these studies. Were they just looking at people with severe? Were they looking at effect sizes of those with severe versus moderate versus mild? Do we really have that data? Um, and is it kind of a mix? So is the data being watered down by patients with mild to moderate symptoms, which are patients we already know respond less well? I mean, I know there is some research out there to suggest that with mild, there's very little response. Moderate, it's kind of iffy, and severe, a slight. But I think there may be some watering down in the research, because not, there's so many studies out there. They're not all done consistently the same way, so that may be detracting a little bit, right? And then in addition to that, getting the diagnosis right can be correct. Now we've talked about, like, I haven't talked about how to diagnose patients, because it's very complex and it's very challenging. It's more than just opening your DSM, right? It's and you're going to get it wrong a lot of the time because it's just not obvious, right? So say you've got a patient that actually has bipolar disorder, but we didn't know that. Well, they may get worse, right? Someone that maybe we thought it was depression, they met criteria for depression, so they were included in a trial, but actually this is more of an adjustment disorder, personality disorder, ADHD, that looks like depression, and we didn't really notice that it was one of these other things, and those things will respond less well to medication. And so we're not really, maybe that's watering things down, right? And then PTSD, sometimes patients don't reveal the traumatic event. Maybe they don't remember it. Maybe there's PTSD going on. That tends to respond a little bit less well than major depressive disorder. Um, and then the type of depression may respond different to different medications. And now that's something we're going to get at in a few episodes from now, where I'm going to talk about psychotic depression and anxious depression and melancholic depression, and all those sort of things. So there's actually specific meds that may respond, depending on what type of depression you have. There may be a medication that they respond to better. And so if you're just kind of doing a study where you're just testing an SSRI against anyone who has depression, well, maybe you haven't picked the right med for that patient. If you had kind of looked into it and thought, oh, this is this type of depression, and SSRI is actually not the first line for this, but I'm testing SSRIs, this person has depression, and so they're going to respond less well, right? So if we do a better job, basically, if we do a better job in kind of figuring out what kind of depression they have, or if they have something other than depression, um, which you may not have noticed. You may have they may have not given you the signs. They may have denied symptoms that would have led you down one of those roads. They may not have had insight into certain symptoms that would have led you down one of those roads. And so if we're including folks here in these studies where they actually don't have major depressive disorder, then yeah, they're not going to respond as well. And so that's probably going to drag our numbers down a little bit as well. So, like, if you've got someone who's got depression and it's a more severe type, and it's a type of depression that responds better to, the treatment that we're starting with, then we're probably going to get better results. And the studies, it's just extremely challenging for them to be able to do that. Now, at the same time, I make the comments that I do about how I don't think these are as effective as, people want them to be, not just because of studies I've read, not just because of effect sizes that I've looked at, but also because of my own personal experience. Like, I've given these medications to hundreds of patients, and I've noticed that responses were, maybe not as great as I'd like them to be. So that's why I'm kind of in line with that. At the same time, if you can improve your ability to give a placebo response, your ability to pick the right med, your ability to respond to certain things with a patient, you may be able to outperform these effect sizes that are kind of listed. Okay. And so you don't want to think, oh, well, that's that way, so I should just not do it. Or if you're a patient listening and you're thinking, oh man, he says these aren't that effective, I shouldn't even try it. Well, I'm not saying that. All right. I'm saying that they're not as great as we'd like them to be, and maybe we need to think about how we prescribe them a little bit differently. Maybe we need to take an angle of, side effect profile first, or if things aren't working, we need to switch them up faster. This just take everything into scope there. The other thing, if you heard the last episode where I talked about the life cycle of kind of prescribing, and we went over the star D, um, the star D at the end of the four medication trials, 2/3 of patients were in remission. That's pretty good, actually. Remission means that they don't meet the criteria for the disorder anymore. 2/3 is a lot. Okay, so to me, an effect size of 0.27 doesn't equate to getting 2/3 of patients into remission, right? Um, it kind of like that 0.27 is pretty poor result, and 67% is a pretty good result, right? So I think the other thing is when you're looking at just like the individual effect sizes of individual meds, you're not taking into consideration, well, we're going to try another one and another one and another one, and we're going to get a little bit more patients better with each new try. And in fact, you may figure out that they have bipolar disorder at some point and end up putting them on a mood stabilizer, right? And then of course those initial trials of meds didn't work because you had the wrong diagnosis. Okay, so that's kind of another thing that I would say. And also, if you look at STAR-D, they were using tricyclics. They were using T3 thyroid hormone. They were using MAOIs. So, and I think a lot of folks out there aren't using these. I think lithium was in there. So they're using some treatments that aren't necessarily being given as an option to all patients. And so maybe they're not getting better because they are just going SSRI to SSRI to SNRI to SNRI and never really trying some of the other things because, there's a concern that, oh, there's more risk with this. I don't want to deal with that risk. And then they don't want to give it to them. But it could get a few people better than if you had not done that. All right. So I think kind of looking at what Star D showed, like, oh, I need to go from one class to another class to another class type of deal. All right. So next point. The patients are, and this next point doesn't have to do with the research, right? So most of this, what I'm talking about is kind of saying, okay, well, the research shows that they're not that great, but maybe they're a little bit better than we think. This one is talking more about kind of real world, like in the real world, and we're just not seeing that good of results, or patients are saying, you got a lot of patients out there, this doesn't work, this doesn't work, this doesn't work. So some reasons for that might be, you know, patients are often kept on the a med too long. And I was actually on vacation recently, and I met somebody, and they found out that I was a psychiatrist, and I ended up answering some questions about their medication, and it's like this person had been on two of the medications I would least want to put a patient on, paroxetine for one, and mirtazapine, which for this patient who had gained a lot of weight on the paroxetine, not a good choice to put him on mirtazapine. So someone has picked two bad choices, and she had been on one of these two meds for the last 3 years, and basically told me that she had never noticed a difference ever until she stopped taking medications. And when she stopped, she felt worse, and feeling worse didn't go away with time. And then she basically got back on medications to make the feelings go away that she didn't have before she started the meds, but that the meds seemed to have caused. And now she's basically just taking them to stop that from happening, but she's no better off than when she started. And I'm just like, they only tried two meds. And she said, every time she goes, it's like they say, oh, just keep taking this, keep taking this. Oh, it's not working. Oh, just keep taking it anyway. It is working. Um, this story I hear over and over and over again. And I don't understand, I hope there's folks out there that are doing this, that are listening to the podcast and like kind of maybe second guessing themselves on this. Like, why are you doing this? If the patient's telling you they don't feel better, why are you continuing to give them a medication? We talked about the life cycle last time. I switch patients after 1 to 2 months, depending on, if they're having a really bad response, or if they're having, no response, I might give it a little bit longer, but like 3 months tops. If we're not where we want to be, 3 months tops on on a certain med and a certain dose, you should definitely not be continuing that medication. Like that makes no sense to me at all. 12 weeks is the longest that you could possibly go to wait for max effect. And also, this is the other thing. She was on like the lowest doses. She was on like 15 mirtazapine and 20 approxetine. The dose had never been increased. But of course, she was having side effects, so the dose shouldn't have been increased. But maybe the reason why she wasn't getting better was because the dose was too low and she needed to be on a med that wasn't causing the side effects so that she could tolerate higher doses. And it's like, and in the country I was in, it was like, you know, apparently they get like extra training to do these things than I got. And I'm like, you had like 12, 15 years of training and you just have someone on the lowest starting dose of the dirtiest med that there is. And we looked it up. I was like, here's all the meds that I would suggest. And we looked to see if they were available in that country, and they all were. And I'm just like, why have none of these been tried? It makes no sense. And so, that's a recent example I had, but like I see it a lot. Like I've seen that same story not just in some foreign country I was in, but in my own country. I see it a lot, and I don't understand it. I'd like to talk to these physicians and be like, why are you doing this? The patient says they feel worse, they're not getting better, yet, and it's been like a year, and you're still telling them to continue taking it. It makes no sense. And so this is a big reason why meds are not working. It's because they're not being dosed appropriately. They're not being changed appropriately. We need to try things of different mechanisms of action. It just doesn't make any sense. Okay, so like there's a lot of suboptimal prescribing going on, and that's a big reason why I'm doing this podcast. Is because a lot of folks maybe don't have this information. They went to school a long time ago, or maybe they didn't get it, or they don't have as much time I do and as much interest as I do to like look all these things up and make this material. And you know here it is. Listen to it on your ride into work and learn something. Hopefully get the word out there that if you're not getting the results that you're hoping for, there's lots more you can do. There's lots more you can do. All right. And here, this next point is actually the point that um, I've thought about for a long time, that I'm kicking myself for not including, and is the reason why I wanted to make this episode today. So it has to do with heterogeneity of response. Okay. So what does that mean? Okay. What that is, you may do this study, and on average, you're getting this, kind of meager response to medication. But people are so heterogeneous, right? They're so different in how they respond. You may get a handful of people, let's just throw some numbers out there, maybe a fifth of people that respond tremendously super awesome to a med, a fifth that have like a so-so response, a fifth that have like no response, a fifth that have like a crummy response, like they get a little bit worse, and then a fifth that like get really bad, right? And then when you average them all together, it may be pretty close to no response. And if it's a little bit more than that, that means that you're having a little bit more of the people having good responses than bad responses. But a lot of people get worse depression when they take antidepressants. Like that's a side effect. I mean, look at the black box warning, suicidal thoughts. You can get a worse response on medications than not taking them at all. And then you got people that like they're cured, right? And when you kind of average them all together, it looks like, oh, it's not that great. And that's why like I'd like to see a study, and I found one. I've been thinking about this for a long time, and I like looked into it, and there actually was a study. I was like, because there's such a variable response to our meds, and I think that goes for any medication in medicine, right? But I mean, it's definitely present in ours, right? I think that what we need to do when we're like looking at how well something works is not like the average of like 4,000 people or whatever and how they respond. It's, can we divide that up into, like, I would divide it into quintiles of like super responders, kind of how I went over there is, different variable quintiles of super to so-so to nothing to worse to a lot worse, right? And see how many of each of those. And there's actually a study that showed that when you're looking at a large response, is what they kind of called it, large response. 25% of patients had a large response to medication versus only 10% having a large response to placebo. And then also, as far as minimal response, 12% of those taking meds had a minimal response, while 22%, so more, had a minimal response on placebo. And so when you look at those two and you kind of divide it out by large response and minimal response, you see that the meds are really beating placebo, right? But then with all the stuff kind of mixed there in the middle and so forth, it kind of averages out to like, so-so. So that's why I say, you never know who's going to respond and how they're going to respond and how it's going to go. You just kind of have to make your best guess, come to an agreement with the patient, give it to them, see what happens, and then have the appropriate response to how they, you know, I often say to patients, and they often look at me funny, like, I don't know what's going to happen. I don't know if this is the best med for you in the year. And it's like, because there's no way to know, right? And I say, but how you respond to this medication is going to give me clues on how to pick the next med. So depending on how if you have a good response with side effects, I might go for a different med in the same class and hope that, and one that's maybe a little bit less likely to get those side effects. If you get a certain side effect, that may make me think, oh, let's go to a different mechanism of action that doesn't cause that thing, right? So that's this first step. Like, even when you look at Star D, the first step, only 33% of people remitted, but after the fourth step, it was 2/3. So we take that information from that first step, and it helps us work through it. And I say that to patients because I want to kind of clue them in on, hey, just because step 1 and 2 don't work doesn't mean that we don't have other options that might not work, right? Obviously, the more failures we get, the smaller your chance of getting better are. But it's never a 0% chance. It's never zero if we try something else. And so it, I mean, if you're doing this poorly and you're not going to get better anyway, might as well try something else, see what happens, right? So that heterogeneity response is something that we don't really get in the studies. It's watered down. And I think it makes our meds, and it probably makes a lot of other meds, look like they're not as good as they are, when all of us that practice out there know that we've seen people get a lot better. They're not getting a 0.27 effect size. They're getting like a 2.0. They're getting like a huge effect, right? And then there's other patients that we know that, like, these meds are like dangerous for them to take because they make them so much worse. All right. Certainly those are less likely, but it happens, right? And we'll never know until we do it. So that is a huge point. And then here's another one that I kind of dug out. The next point on, like, the counteracting, like, the effectiveness argument. So when you look at how these studies are done, how, like, I already said before, they don't really mimic the real world. So they have to try and be as consistent as possible. And that's hard to do. And one thing they do is they use rating scales, and they use different ones. The thing is, when I was, practicing in the military, we frequently use the PHQ-9. It's quick to fill out. It's 9 questions. The patient can fill out the whole thing by themselves. Um, and basically each one of the 9 is one of the symptoms in the DSM for depression, right? So, but if you look at the HAM-D, there's a lot more in there. And if you look at the HAM-D, and it's often what's used in these studies, there's only one question about depression. Look at the Beck. It's only one question about feeling sad. Same with the PHQ-9, but there's less questions on the PHQ-9 as well. When you've got like 22 or 23 questions and you only have basically one question asking them about depressed mood, I mean, just because they're not having some of these other effects doesn't mean that they're not depressed and might respond to a medication, right? And it also, like, it may not elucidate what's, and so if you look at some of those questions, they're not even symptoms of depression from the DSM. They're not they're things that could be related. They may help kind of shows some people that are more severe, but they're not even necessarily symptoms of depression. And sometimes you've got maybe one symptom from like the list of in the DSM, and there's like three questions that all are about that one thing. So there's like more weight given to it, whereas maybe what's more bothersome to them, um, how they're feeling, is got much less questions, and so we're getting a lower score there. And say that thing got better, but a lot of other stuff didn't, and they feel much better because of it. They're like, oh, the one thing that I really cared about is better, but my scale only dropped by 3 points, so it doesn't look like I got that much better. But the thing I really care about did, right? We have no way of measuring that. We have no way of knowing, right? Unless you're actually the one treating the patient. Like if I treat the patient and their scale goes from a 28 to a 25, but like all three of those points were in the number one symptom that's important to that specific patient, then they feel way better. But it looks like they barely got better at all. Okay, so that's another thing. The scales, they there are attempt to be objective and to be like, I talked about, I went on about this a lot in the last episode about like how we don't really have rads and labs to like assist us, and we try and use these arbitrary things like, and I listen to a lot of podcasts and a lot of smart people on there. I wish I would love to be invited as a guest on a show, but I never will be, because I'm not one of these people that's at the forefront of the field. I'm not doing research. I'm not at some university leading a department, right? But in many cases, when I listen to these people, um, I see the bias that they have. When you're at that level, there's a lot more, um, a lot more connection to industry, and also just a lot more connection to their own research. So like a lot of them like invented scales. Like they came up with their own scale to measure some specific thing, and they just push the heck out of this scale. Like they think it's the end all be all. And I mean, I already gave my opinion in the last episode about scales. I think that they are not that useful. And that you hear these people talking about how useful they think they are. Oh, these, and if you just use this scale, and in many cases you have to pay for some of these scales, especially if you're a big institution. And it's like, I feel like, once again, this goes back to, if you go to my like very first episode where I talk about like my ethos, I am like anti this kind of bias that money kind of puts into the system. It was like awesome for me to work in a system where like my performance was not, there was no connection with what I made and like what I did in my job. I was paid based on my job, my years of service, and my rank. And in the military, you do not gain rank from being the greatest physician ever. You gain nothing. You could be the greatest physician in the military and never go up in rank. That's not what helps you go up in rank. It's a bunch of other arbitrary nonsense. And I'm sure that that's the case outside the military too, because nobody knows how. The only people that know how good of a doctor you are your patients. And they're not the ones, because this is a private interaction between you and them. Your boss doesn't know, necessarily. They may have an idea, they from talking to you and like other colleagues that have respect for you, there could be some way of knowing there. But for the most part, everyone's kind of assumed, oh, you're a doctor, you're doing your job, right? So that that becomes that becomes a factor. All right, so I there was no connection between my performance as a physician and any connection to making money or selling anything, or like nothing. I had that's a big reason I'm doing the podcast, is because I hate that crap. And when I hear these people that like have a lot of good things to say, and they're like at the top of their field, and they've done billions more research than me, and they're like promoting something that like I know that they're probably getting money. I can tell, and then I'll look it up, and yeah, they're on some paper for this med being approved. They're like doing lectures for this drug company. Yeah, because the same people that are like famous and out there and doing that stuff, they're also the ones that industry is hiring to do their promotions. And they may not realize they're biased, but they're biased. If you're doing that stuff, it's almost impossible not to be biased. If I was ever asked to do that, I would only sign on if I could do exactly what I wanted. And the drug company would never allow it. They'd be like, no, we want, like you're saying some things that are like somewhat questioning us and somewhat critical, and it's like, yeah, because this is not a perfect product, and I want to be honest and put the real information out there. I may think you have a great product. I may think that, hey, we need to go and I think this, I would advise lots of patients to take your drug, but that's not to say that there aren't patients I wouldn't advise. That's not to say that there's not some downsides, and they're not going to want you to talk about that, so they would never ask me to do that, right? And so I'm never going to become that prominent person, right? And I'm never going to be inventing my own scales and promoting my own scales. So these scales, there's so many reasons why they are not that useful. I talked about before, it's patients don't want to, a lot of patients don't read them. A lot of patients, like, they, you can have them fill out the same scale 3 times in the same day and you get different answers. Um, a lot of people just mark straight zeros or straight threes, and they come and I'm like, well, it looks like you're doing better. And they're like, no, I'm not. I'm like, you put straight zeros. And they're like, oh yeah, I wasn't really paying attention. Or like, wow, you're really not doing well. I was like, yeah, I am. And I'm like, you have almost a max score on your scale. I see this all the time. There's like so, like there's just so little correlation there. And there's so many reasons for it, from not reading the question, not understanding it, trying to fill it out too fast, not wanting to fill it out, feeling annoyed by filling it out, um, just having, not really having a good ability to say, oh, this is how I've been doing the last 2 weeks, and not reading that sentence at the top of the page and just saying how they feel in that moment. And maybe they had something really crappy happen to them on the way to your office that has nothing to do with what you're treating them for, but it's completely altered the way they fill this scale out. And so these these scales are notoriously difficult to decipher. And they are the sole thing that's being used in these studies to show how effective these medications are. Okay. Um, and the other thing about the symptoms being heterogeneous, different patients may be more affected by different symptoms as well. Like somebody is really bothered by their sleep, whereas someone else is really bothered about their interest in sex, while someone else is really bothered by um, feeling like they're a piece of garbage. And different scales may give different weight to different things, and um, it's really, it tries to be objective, but ultimately it is subjective, and it's qualitative, not quantitative. We're not able to get a perfect read. That's where you come in, right? That's where you come in as a professional and an expert, and you form a relationship with the patient. You talk to them about the stuff going on in their life. You get to know them. You form a good communication, and you get in a good team, and you treat, and you understand them, and you give them a treatment, and you see how it goes. And like, I've had scales get worse, and the patient be like, "I'm good to go," and I've had scales get way better, and like the patient says, I need to change, this is awful. So like, that's a big problem. I mean, these effect sizes, maybe when we have big numbers, a lot of this averages out, and like these scales are validated, you know but there's just so much bias in a lot of this. And then there's just so much. Are they valid? Yes. But are they giving us a super accurate depiction? Probably not, right? What they are showing is that the meds are working. They're just showing that they're not working that well. Okay? So they're giving us a positive signal, but I think they might, in some patients, watering down how well they're doing, and some patients watering down how bad they're doing. Okay? Remember, it's an average. Um, and here's another thing, right? About the point I made about like different symptom clusters, right? Whenever there was another study, when you looked at the scale as a whole, the effect size was 0.27, but when you just looked at the depressive symptoms on the scale, effect size was 0.4. So, which for most people, that's the symptom that's the most bothersome to them. And when you look at that one, the effect size was actually quite a bit better. I mean, it moves from like barely effective to kind of more in the moderately effective category. So that can make a huge difference. All right. And then one last point to make is that when you look at the effect size for for psychotherapy, it's basically exactly the same as the meds. And so this idea that like, the meds don't work, well, the therapy If you say the meds don't work, the therapy doesn't work either. And a lot of medical treatments out there are really effective, but a lot of them are kind of similar effectiveness as antidepressants. And I think antidepressants get picked on for being like the ones that are the least effective. And one reason for that was whenever I don't know who it was, but they were on 60 Minutes like 15 years ago, and whenever they did this study to kind of look at how effective are these, they could have chosen any medication. I forget why, but they just happened to decide to choose antidepressants when they did that study. If they had chose another medicine, they may have found the same information, and then it would have been cholesterol meds or pain meds that would have been like, oh, these don't really work, kind of thing. And so it but antidepressants were like a big focus of a lot of these studies, and so that's why their effectiveness is often called into question more so. All right, so those are all my points in the effectiveness kind of rebuttal part three that I wanted to put together. That doesn't mean that what I said in part one and part two I don't fully agree with. I don't think that these meds are as effective as we need them to be. They don't work for everyone. You've got, even in the most ideal of conditions, a third of patients are not getting into remission, even with multiple trials. Um, but that's not to say that we shouldn't use them, right? I don't think that we should be overly confident in how well they work. And I think that that can lead us to do things like I mentioned the story about the person who was put on a medication and the dose was never changed, the med was never changed. I think that kind of having a picture of reality of how these meds actually work and how well they work, it's going to give you the ability to make them work better. If you don't have an accurate picture of like what's actually going on, you're not going to be able to prescribe them as well as if you did know that information. Okay, so there are two sides of a coin. In many cases, these work really well, and in many cases, they don't. Um, and I'm hoping that after listening to all my episodes, that you will have a better understanding of when to use which med, how to use it, what to tell the patient about, what to look out for, when to change, what to do, when to add, when to switch, um, how to interact, and at the end of the day, get the best thing you can. Because if they don't come in for anything because they think that this stuff doesn't work, then they're definitely like not going to. I mean, I'm not say they're definitely not going to get better. They could make changes within themselves, or their circumstances could change, and I that's great. If you're like, I'm not ready to do this yet. I want to try, some behavioral modifications on my own. I want to try some therapy first. I think that's amazing. You know, but if you're basically like dead set against meds because you like heard all the bad things about them and none of the good things, and you never take them, you might be one of the patients that was going to get better from it, and then you never find out. And like, really, there's so little downside here. These meds are like very little risk, but like the patient I told you about before, like now she's gotten these, she was put on a med that didn't work for so long that it's like really messed up her brain chemistry. And now she's having a hard time coming off. I think that I could help her. I would switch to something else because I think she might respond to the right med, and she just hasn't been given it. And I think that would also help prevent her from going into these relapse symptoms she had, and also give her a benefit. And I think if ultimately the meds weren't the answer, that we could slowly taper off in such a way, and maybe add something to combat these, and get her to a point where she didn't need them anymore to combat those symptoms. But a lot of folks out there just aren't working with that. They're not trying to do it, and it can be done. And there's a lot of great people out there that are doing great stuff, and then there's a lot of people out there doing really mediocre work. I've seen a lot of mediocre work, and I hope to be a part of making that better. So I hope, if you thought that I was a little too overly negative and I didn't give enough positive points, um, I presented some today. I dug up a few more. Um, try to give a balanced thing. Like I said, I'm not a med pusher, but I'm also not like an anti-med person, obviously. And I'm not putting this podcast together to educate people about all the bad stuff about why they shouldn't do this. It's so that I don't want the negative stigma. I don't want the bad information out there. I want the realistic picture. Let's try it, but let's do it right. If it doesn't work, let's get rid of it, right? It's not for everyone. But that doesn't mean that if you might not be a candidate to give it a go. And here's the other thing. Um, One more thing that was reminded to me about that patient I met a couple weeks ago. Not a patient of mine, but a patient of someone's. Um, she had a very poor relationship with her psychiatrist. Didn't trust him, yet still took the meds. Right? There's a lot of people out there that they will not stop the meds, and it sounds like she did, but then felt worse from it, so continue taking it, and is not able to get on anything else. But and I told her, like, 80% of it is your faith in this working. The placebo is real. And she was like, what? And I was like, yeah, it is. If you don't trust this person, she's like, I don't. It's like, if you don't think that they know what they're doing, she's like, I don't. It's like, if you don't have a good relationship, I don't. Um, and you don't believe the meds are going to work, and you don't feel like they're getting, then you're not going to get better. And I mean, I basically talked to her for 45 minutes. I looked at her meds. I told her what I thought of them. I gave her a list of all the meds that I think are better and the few that I would probably pick in her case that she could bring to her doctor, and maybe he'll listen. It sounds like he doesn't. The other thing is, he doesn't listen to her. She comes and says, "Hey, can I do this?" And he's like, "No, we're doing this." Dude, what are you doing? That's terrible. Don't do that. I mean, unless you've, I mean, unless you've got a patient that's just like so out of it and so low insight, like this, you need to at least attempt to get on the same page with the patient. Come on. So, and after that 45 minutes of talking to her, and of course we didn't even go into everything. I didn't even find out what are her symptoms. I didn't give her an appointment. I was just kind of like giving her opinion on the meds she was taking and kind of giving her like some information on what I thought might be better. But I don't know which one I would pick because I didn't actually have an actual appointment with her. I didn't like assess all of her symptoms and stuff. I mean, I would do that too, but even and this is the thing I mentioned, I think in the last episode where I said I don't necessarily always do a full exam. Um, because I think going through it, just like I don't just hate the scales in the in the waiting room. I hate the packet of all the questions people have to fill out. I think it's all nonsense. Like, I mean, it is for me anyway. I just I want the background information. I want to know the background of what I want to know is I want to know what you've taken before, when you took it, and for how long. So, like, I like to get that out of the medical record. In the military, I had access to that. I'd like to know how many times you've been seen, how long you've been seen for, and I'd like to see maybe a note from somebody else that shows kind of what happened. I don't really want what you filled out in the waiting room. I want some background medical history, and then I want to gather the rest, like, face to face. Um, I think that other stuff, it just I just don't, it doesn't do it for me. So, as I was saying, I do a more focused kind of session with the patient, and like, I had formed such a like strong connection with this person after just talking about a few things that she had just never heard before. And she was just like thanking me and hugging me and like, walking me out and offering to, like, get me a ride to go with the next place and stuff. But it's like, it's like, and I'm not the most empathetic and personal person, as I've mentioned before. Like, it's something I strive to do. It's something I try to do better, but innately that's not who I am. But what I do is I want to, let the patient speak, hear them, give them information, work together. And the other thing was, I was saying, I bet you're having this symptom. I bet you're having this. I bet you're having this. And I was right over and over and over again. right? It's like, I bet you're having this side effect and this side effect and this side effect, and I bet that this is what's happened, and I bet you've gained weight. She's like, I've gained 20 kilograms. So like so she already doesn't feel well about herself, and now she's 20 kilograms heavier. So this is just an example, and it's something. It was one of the reasons why I wanted to make this episode, is because this story, and like, I haven't been like, I'm about to start like doing some volunteer work, practicing again, but I haven't practiced for about a year and a half now, and just having that encounter and just like kind of remembering, and like, yeah, that's what happens. And this is a big reason why these meds don't work. And like, if I can instill that hope and that connection, I build that placebo. I build that faith. And I also get rid of a med that we know is not working, and put something new into the mix, get some new hope and a new thing, something that's not going to cause the same ill effects that the one we were taking before was. And hope, I don't know whether there's a better result or not. Only time will tell. But it's certainly a lot more likely you're going to get it if you're able to do that, right? And like, you're not a machine. This is not just your job. Like, to me, like, you could see 1,000 patients, and if 999 of them don't get better, you might as well have not even showed up, right? If I see 50 patients and 40 of them get better because I spent more time, like, okay, a lot of patients didn't get seen, but they weren't going to get better anyway, because I wouldn't have had time to get them better. Better to take the time and do it right, because if you don't, you're just basically spinning your wheels. You're just checking boxes, putting a check in the bank account. Oh, every patient I get paid for, everything I do I get paid for. But are you really doing anything? The whole purpose of you being there is to get patients better. And I see that not happening a lot. Now, I'm talking about the negative side. Obviously, there are cases where this is totally not the case, and people are doing fabulous, right? Um, but especially, for patients out there, I want to let you know that, like, it's not always like that. If that's the experience you're having, if you're like a trainee or a student, and maybe you're seeing that in your instructors, that's not always the way it is. Or, maybe if you're getting burned out and you're seeing the same thing, you're starting to, think the patients are like the problem, um, then like, readjust, right? Like, why did you go into this? To help people, right? Are you helping people? No? Well, make a change. Don't just get a paycheck and go through the motions. There are people, you can do better, right? And that may mean making some significant changes to how you do things. Um, but that's why I have 3 episodes on effectiveness, to kind of like try and like just talk about that. It goes through everything, but like, just to have 3 episodes where we really, really talk about that. So I will not ramble on any further. Hope you enjoyed this episode. Hopefully, that if I was making you feel too negative before, you've kind of thought, oh well, he's not like super anti-med. He's just anti a lot of stuff that's going on out there. But thank you. Please tune in next episode. Please rate, leave a review, and I'll see you next time. Don't sell me short. Don't sell me down the drain.